Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. When we hear appendicitis, many of us probably think it's a pretty straightforward diagnosis, right?
Yeah, that's the common perception.
But our sources today show it's, well, way more complex. Acute appendicitis is actually the #1 reason for emergency abdominal surgery.
Right.
Yet diagnosing it can be, and I'm quoting here, extremely difficult.
Mm-hmm. It really can be.
So our mission in this deep dive is to walk you through this fascinating world of conditions that actually mimic appendicitis. You'll be surprised.
Definitely.
We've pulled together a stack of expert sources for you, so let's get into it.
Okay. And what's really striking, is how the body can send out such similar signals for problems that are actually, well, completely different underneath.
Right.
That difficulty in diagnosis comes because so many common things can look like appendicitis.
And it changes, right, depending on who the patient is.
Exactly. The list of suspects, let's call them, really differs in patients of different ages. That's key. And particularly in women, additional differential diagnoses are diseases of the female genital tract. That adds a whole other layer.
It really sounds like walking a diagnostic tightrope.
That's a perfect way to put it. It really is.
Okay, so let's start walking that tightrope, maybe with the youngest patients first. Children.
Good place to start, yeah.
I imagine when little kids are in pain, figuring out why is extra tough. Their symptoms must be hard to read, which I guess leads to more misdiagnosis.
You've hit it right there. It's very challenging. For
Yeah.
a doctor, it's like being a detective, absolutely. The usual suspects in kids?
Yeah, what are they?
Well, the most common ones are acute gastroenteritis, a bad tummy bug, and something called mesenteric lymphadenitis.
Mesenteric lymphadenitis.
Yeah, essentially swollen glands in the belly, often after a virus. You can sometimes tell it apart because the pain is more colicky in nature. It comes and goes in waves.
Okay.
And sometimes you might even feel swollen cervical lymph nodes, glands in their neck. That's a clue.
Interesting. What else?
Then there's Meckel's diverticulitis. Now, this one is really tricky. It may be impossible to clinically distinguish from appendicitis.
Impossible. Wow.
Yeah, the pain feels very similar. Sometimes the signs might be more central or left-sided, not the classic right lower quadrant.
Mm-hmm.
And maybe, just maybe, there's a history of antecedent abdominal pain or intermittent lower gastrointestinal bleeding. Little clues you have to dig for.
So it's not always that classic right-sided pain. That's crucial. What about intussusception? I've heard that term sounds serious.
Oh, it is. And making that distinction is critical. See, appendicitis is actually uncommon before the age of 2 years.
Right.
But the median age for intussusception is around 18 months. So different age group, typically.
Ah.
And here's where the detective work gets interesting again. Sometimes a mass may be palpable in the right lower quadrant, like a sausage shape.
You can feel it.
Sometimes, yeah. And fascinatingly, the first line of treatment isn't always surgery. It's often reduction by careful barium enema.
Barium enema.
Yeah, they use a contrast liquid, barium, introduced via enema. And the pressure can sometimes gently push the bowel back into place. It diagnoses and treats it.
Wow. Using the text as the treatment. That's pretty clever.
It is, isn't it?
Are there other childhood curveballs, things that maybe don't even seem like a stomach issue at first?
Absolutely. Take Hinoch-Schönlein purpura.
Okay. Bit of a mouthful.
It is. It's basically inflammation of small blood vessels. It often follows a sore throat or a cold. The abdominal pain can be severe, really mimicking appendicitis.
So how do you spot it?
The big clue, nearly always, is a specific type of rash ecchymotic, like bruises, usually on the arms, legs, buttocks, but the face usually spared.
Rash.
Yeah. And lab tests show normal platelets, normal bleeding time, but often microscopic blood in the urine, hematuria.
Okay, so look for the rash, check the urine.
Exactly. And here's a real surprise. Lobar pneumonia or pleurisy, lung inflammation.
A lung problem mimicking appendicitis.
If it's in the lower part of the right lung, the inflammation can irritate nerves that also go to the upper abdomen. It causes right-sided abdominal pain.
Referred pain.
Classic referred pain. You differentiate because the abdominal tenderness is often minimal, but the fever is marked, like 39 Celsius, 102 Fahrenheit.
High fever.
Right. And listening to the chest, you might hear a pleural friction rub or just different breath sounds. A chest radiograph is diagnostic, of course. An X-ray clears it up.
So the takeaway for kids is you really have to look beyond the belly, right? even check the chest.
Absolutely. Broaden the search.
Fascinating. Okay, let's shift gears to adults. The diagnostic puzzle probably gets even more complex there, doesn't it? New mimics enter the picture.
It does. The landscape changes. In adults, one major condition to consider is terminal iletus.
Inflammation of the end of the small intestine.
Precisely. In its acute form, it can be clinically indistinguishable from appendicitis.
Again, just like Meckel's in kids.
Yep. Unless, sometimes, the doctor can feel a sort of doughy mass of inflamed ileum. But often, the clues are in the history. An antecedent history of abdominal cramping, weight loss, and diarrhea.
Yeah.
Long-term gut issues.
Suggesting something more chronic, maybe?
Exactly. Could be Crohn's disease or maybe an infection like Yersinia. That one's interesting because it causes inflammation of the terminal ileum, appendix, and caecum, so the whole area is inflamed, plus swollen lymph nodes.
Wow, so it hits the appendix too.
It can. If you suspect Yersinia, blood tests for antibodies, serum antibody titers, can confirm it. And surgeons might approach it differently if they find it during an operation.
So a history of chronic gut problems is a red flag for something other than simple appendicitis. What about kidney issues? Can they cause similar pain?
Definitely. Ureteric colic pain from kidney stones usually has a pretty distinct character and radiation the way the pain travels, often less confusing.
Okay.
But right-sided acute pyelonephritis, a kidney infection, that can be trickier.
How so?
It's often preceded by increased frequency of micturition, needing to pee more often. The tenderness is usually more confined to the loin, the flank area.
Uh-huh. Higher up, sort of?
Yeah, on the backside. And typically a high fever, temperature 39 degrees C, maybe rigors, chills, and pus in the urine. Pyuria.
Got it. Kidney infection signs. What about something really acute, like a perforated ulcer? That sounds like its own emergency.
It absolutely is.
Ah.
And it can mimic appendicitis because duodenal contents, stuff from the upper intestine, can leak and track down the right side of the abdomen, pooling in the right iliac fossa where the appendix lives.
Oh, wow. So the pain ends up in the same spot.
It can, yeah. But the start is usually different. Appendicitis pain classically starts in the umbilical region, around the belly button, then moves.
Right.
An ulcer often has a history of indigestion, dyspepsia, and crucially, a very sudden onset of pain that starts in the epigastrium, the upper middle abdomen, and passes down the right paracolic gutter.
Sudden and starting higher up.
Exactly. And while both cause rigidity, that stiffness in the belly, with an ulcer, it's usually greater in the right hypochondrium, the upper right side. And a key test, quick and easy, is an erect chest radiograph, standing chest x-ray. It shows gas under the diaphragm in 70% of patients if there's a perforation, air where it shouldn't be.
That's a clear sign. So it's not just that there's pain, but the story of the pain, where it started, how fast, is crucial.
Absolutely critical. Those details matter immensely.
Any other adult mimics that might get missed?
Yeah.
Things that are less obvious?
Yes. Testicular torsion needs mentioning, especially for teenage or young adult males.
Torsion, the testicle twists.
Exactly. And the pain can be referred to the right iliac fossa. Feels like appendicitis.
Wow.
Which is why a scrotal examination in all cases of lower abdominal pain in young men is just vital. Can't skip it.
Makes sense. Anything else?
Well, acute pancreatitis is on the list, but it's usually excluded pretty quickly with a blood or urine test for amylase.
Okay.
And then, a bit rarer but easily missed, rectus sheath hematoma.
A bruise in the ab muscles.
Essentially, yeah. Bleeding into the rectus abdominis muscle often happens after strenuous physical exercise. You get localized pain without gastrointestinal upset. No nausea, vomiting usually. You also see it in elderly patients on anticoagulants, blood thinners, sometimes just after minor trauma.
Right. Easy bruising. That's a lot for adults.
Yeah.
But then for women, you mentioned there's a whole extra set of possibilities.
A whole additional chapter, really. These often become the most crucial things to rule out.
Okay, what are we looking at here?
Primarily, pelvic inflammatory disease, PID. It's an infection of the uterus, fallopian tubes, ovaries.
Right.
Its incidence is rising, and you have to consider it in every young adult female with this kind of pain.
How does it differ from appendicitis pain?
Typically, the pain is lower than an appendicitis and is bilateral on both sides. That's a major clue.
Lower on both sides. Okay.
History might include vaginal discharge, dysmenorrhea, painful periods, maybe burning pain when urinating. And on examination, a pelvic exam reveals adnexal and cervical tenderness, pain when moving the cervix or pressing near the ovaries.
Okay. Requires specific tests too, I imagine.
Yes, specific cultures are taken, and often Getting a gynecologist's opinion is really important.
Makes sense. What about pain linked to the menstrual cycle itself?
A good point. There's mid-cycle rupture of a follicular cyst, commonly called Mittelschmerz.
Mittelschmerz, middle pain.
Exactly. It's characteristic mid-cycle abdominal and pelvic pain when an egg is released. Usually systemic upset being rare, no fever, not feeling generally unwell. Pregnancy test is negative, and symptoms tend to subside within hours.
So timing within the cycle is key.
Very key. Then there's torsion or hemorrhage of an ovarian cyst, a cyst twisting or bleeding. This one can be a difficult differential diagnosis.
Hard to tell apart from appendicitis.
Yes, very. It absolutely requires a pelvic ultrasound and a gynecological opinion.
Ultrasound seems crucial for women's pelvic issues. What about ectopic pregnancy? That sounds incredibly serious.
It is, and it's one of the most critical mimics because the signs of a right-sided tubal issue, like an abortion or unruptured pregnancy in the tube, are very similar to acute appendicitis.
It's a similar pain again.
Very similar. But there can be subtle differences. The pain might commence on the right side and stays there. It's often severe and continues unabated until operation.
Doesn't move around like classic appendicitis.
Right. And history is paramount. A missed menstrual period, maybe a positive urinary pregnancy test. Examination might show severe pain on cervical motion.
Okay.
And importantly, signs of intraperitoneal bleeding, internal bleeding. You might even ask about referred pain in the shoulder.
Shoulder pain from internal bleeding.
Yes, blood irritating the diaphragm under the ribs can trigger nerve pain referred up to the shoulder tip. It's a classic sign.
Wow.
Pelvic ultrasonography is non-negotiable if ectopic pregnancy is even a remote possibility. It's a race against time.
Absolutely critical. It's just astounding how many different problems can present so similarly. This demands real detective work.
It really does.
Let's widen the net even more. Are there less common things, maybe rarer conditions that can still mimic appendicitis?
Yes, definitely. Back to the gut for a moment. Right-sided diverticulitis.
Diverticulitis is usually left-sided, though, isn't it?
Usually, yes. But if someone has a long sigmoid loop, a variation in anatomy, or just develops it on the right, it may be impossible to differentiate without imaging. And interestingly, right-sided diverticulitis is more common in Asia.
Huh, didn't know that.
In these cases, especially in patients over the age of 60 years, an abdominal CT scanning is particularly useful.
CT scan helps sort it out.
Okay.
Can other gut problems like blockages or even cancer get confused with appendicitis?
We can. Sometimes acute appendicitis can actually cause an intestinal obstruction in the elderly, or the obstruction itself mimics the pain. And carcinoma of the cecum cancer in the first part of the colon might mimic appendicitis or can block the appendix, causing a secondary appendicitis.
Oh, right. Obstructive appendicitis.
Exactly. Clues there might be a history of antecedent discomfort, subtle changes in bowel habit, or maybe unexplained anemia.
Things suggesting a longer-term issue.
Correct. And then you get into the really quite rare differentials.
Like what?
Things like preherpetic pain, the pain from shingles before the rash appears. It's localized, very sensitive to touch, marked hyperesthesia, but no gut upset. The rash comes later.
Right, shingles pain.
Spinal conditions too, nerve root compression causing referred abdominal pain. But usually intestinal symptoms are absent, and there might be stiffness in the lower back.
So even back problems.
Yeah. Then you have abdominal crises of porphyria and diabetes mellitus.
Yeah.
Metabolic disorders where urinalysis is key. Cyclical vomiting of infants or young children, usually a history of it happening before, and the belly isn't rigid. And finally, something very rare but serious in immunosuppressed patients. Typhlitis or leukemic ileocecal syndrome. Severe inflammation in that same area.
Goodness. So recapping here. We've gone from a simple tummy bug to kidney stones, ovarian cysts, testicular torsion, even lung infections and back problems.
It's an incredibly diverse list.
All potentially masquerading as appendicitis. It really shows how complex the body is, doesn't it? And how confusing its signals can be.
Absolutely. And if you connect this to the bigger picture, it underscores just how vital a really thorough patient history is. You have to listen to the story of the pain.
Right, the history, the exam.
Exactly. A careful physical examination, and then using diagnostic tools like ultrasound or CT, wisely, judiciously. Even for this most common surgical emergency, getting the diagnosis right often means carefully ruling out all these mimics.
Finding clarity by eliminating the less obvious possibilities. You know, Ultimately, this deep dive really hammers home how misleading our body's warning signs can sometimes be. And maybe the real art of diagnosis isn't just figuring out what something is, but maybe it's just as much about understanding everything it isn't, that careful process of elimination.
That's beautifully put. It's that meticulous process of considering and excluding being that medical detective that leads you to the truth.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.